First of all, I want to thank the organizing committee for the invitation and the opportunity to share our case and to describe a novel balloon-assisted catheter unknotting technique which we used to manage with a complication that we had during our case. I do not have any potential conflict of interest. And let's go to a case. Our patient is a 48-year-old obese man who admitted to our cardiology department with symptoms of unstable angina. He has history of coronary artery disease, PCI of LAD and diagonal branch 2 years ago with implantation of 2 stents, history of hypertension and diabetes type 2. Due to his symptoms and history, it was decided to proceed for coronary angiography, which was performed from right radial approach. Because of severe tortuosity of right subclavian artery, our standard JL 3.5 diagnostic catheter could not manage to cannulate the left main. So, as you can see in videos, an Amplatz left 2 diagnostic catheter was used for left coronary angiography. And then the right coronary angiography was performed with a JR4 catheter without problems. The Coro demonstrated, The Coro demonstrated an angiographic intermediate lesion of distal left main, patent the stents of LAD and diagonal, and no other significant lesions of the remaining vessels. To evaluate the severity of the distal left main lesion, it was decided to perform an FFR measurement, and for this purpose, a contralateral support 3.75/6 French guiding catheter was used. Due to severe tortuosity of subclavian artery, we encountered difficulties in catheter tip movement during the engagement of the left main, and suddenly we felt a resistance in contrast ejection when simultaneous damping of arterial pressure tracings on the monitor. As a result of our excessive manipulation of guiding catheter plus the significant subclavian artery tortuosity, it was the development of tight knot of guiding catheter in the region of right subclavian artery, and inability to move backward or forward the catheter or to rotate it because of any movement or rotation of the catheter caused significant pain to our patient. There are several techniques have been described in literature regarding catheter unknotting and retrieval. The simplest one is a clockwise or counterclockwise catheter rotation. Advancement of a standard guide wire or a stiff or super stiff wire inside the knot and trying to loosen the knot and unravel the catheter. The external fixation of distal part of catheter by applying manual pressure or blood pressure cuff. A long sheath and sheathless guide catheter technique. A balloon retrieval technique. A delivery from femoral access of snare loop of second catheter or endoscopic forceps to try to catch or hook the distal part of catheter, aiming to extract it. And if all these percutaneous methods don't work, then the surgical extraction is an option. We tried several previously described techniques in our case. We tried with stiff guide wires. We tried the balloon retrieval technique. We delivered a snare loop from femoral approach and tried to catch the distal part of catheter, but all these methods finished without success. So after failure of mentioned techniques, we decided to proceed and try a novel technique, yet unpublished, which we called balloon-assisted catheter unknotting. From femoral approach, a multi-purpose guiding catheter was advanced to right subclavian artery nearby the knotted catheter, through which guide, a floppy guide wire, BMW in our case, was advanced distally to the brachial artery. Over this wire, a large coronary angioplasty balloon, 5 mm diameter, was placed distally of the knot on the distal part of catheter and inflated at 14 atmospheres. This inflated balloon managed to fix the distal part of catheter and permitted us with a gentle counterclockwise rotation to unravel the catheter and finally extract it from right radial approach without complications. Here's forward angiography from radial sheath and the extraction of catheter. Here are the photos of of the guiding catheter and the diagnostic catheter which we used, with a notching on them from the subclavian resistance, from subclavian tortuosity. And what we have learned from this case is that severe tortuosity, subclavian anonymous artery in combination with excessive manipulation of catheter during costal engagement, especially from right radial approach, are the main causes for catheter knotting. And the balloon-assisted unknotting technique is a novel, simple to perform technique for retrieval of kinked catheter, which obviates the need for complex instrumentation and surgical intervention. Thank you very much.
Any comments from the panel?
It's very interesting method to deal with this complication. But you didn't perform any angiography at the final, after the balloon inflation and the catheter retrieval?
Yeah, we had performed angiography with, there were no dissection or perforation of subclavian artery. He had consultation with our vascular surgeons. And we performed finally our FFR from femoral approach. It was negative, so next day he was discharged from our department.
Excuse me, I'm glad to see results of your procedure, because it's a very stringent, it's a very interesting and useful for us. But what do you think, come back in the start of this procedure, if you guide wire through inside of catheters and during multiple and during a lot of rotation catheter use within guide wires, it's more useful, interesting, and without a problem which we can see during your procedure.
Yes, thank you. Yes, the prevention of this complication, of course, is to have a guide wire inside the guide to prevent it. But because of many manipulations, we couldn't manage. And I pulled the guide wire and asked the patient to take a deep breath to elongate the aorta. So, and we had that. Of course, we knew that, but because we couldn't engage, so we tried to pull the guide wire and had this complication.
Actually, you see, what happens when you have, this happens very often in the cath lab. So when you feel that there's some resistance or there's a kink in any part of your guiding catheter, the first thing is to get your eye to the area of the kink. Do not move your guiding catheter. In this case, you had difficulties because there was already a kink there, and when you pull it back, you actually further tighten the kink. So what happens here is you can still salvage it by putting an 035 wire inside, slowly pushing your catheter forward so that it gets unkinked, and then slowly, depending on which way you rotate it, you can use multiple views. You can actually unturn holding your sheet, pushing your 035 wire. You can actually go through and then take it out. You will never perforate your guiding catheter or your diagnostic catheter with an 035 wire. But you have to be very careful. You have to analyze the situation. Most of the time it's done by the fellows, the juniors, and they get very tension, and that's why they keep pulling it back.
Thank you.
Any comments from the audience? Yes, what we've done is leaving the guide wire inside the catheter to be able to twist to one side or the other, and then you avoid the problems like this. And mainly for those who do one single catheter for both the right and the left, if you leave your guide wire in, then you can turn one side and another without having this kind of complications. So if any other comments, if we don't have any other comments, we're going to move on to the next speaker, and thank you very much.